welcome to a new session. Today we are going to be talking about the scenario-based design and evaluation, and we are going to be looking into a couple of case studies. The learning objective for the session is to discuss the relevance of a scenario-based design approach in the development of health information system. Without further preamble, let's start with the first case. And this one is a paper published in 2009 in the American Informatics Association Annual Symposium Procedures, and it was published by Sayas Kavad, Marquardt, Radhakrishnan, Dufay, Everdeen, and the title is Scenario-Based User Testing to Guide Consumer Health Informatics Design. This is an interesting paper that allows to introduce some concepts that we are going to be deeping on and to review some of the ones that we already exist that we already have explored. The human factors research is what is informing this paper, and it tells that human factors can guide both the design and the evaluation of consumer health informatics intervention, and in this case they are going to be evaluating a consumer health informatics tool. And it can also enable designers to understand the different interactions that the humans have with different elements of a system. And it allows them to optimize the performance and the well-being in general when they are interacting with the system. When we think about the human factors methods, they are addressed in this paper three basic concepts: the physical ergonomics, the cognitive ergonomics, and organizational ergonomics, or macro ergonomics, or process ergonomics. Then if we think about the first principle, that is the physical ergonomics, this is related with the different physical characteristics that the user has and is going to facilitate or be on the way to interact with the work environment or the outcome. And we need to think that users, especially those that are chronically ill, are going to have diminished physical capabilities. And when we are aging, then we are going to have less motility, we are going to have less visual acuity, and we are going to be slow in response, less reflexes. But also we can have people that actually they have some conditions that are going to limit the way that they interact with the world. Then we need to be aware when designing consumer health informatics intervention, we need to fit the physical characteristics of the individual and the existing physical characteristics of the environment, and we need to create a bridge there in those needs. And sometimes we need to enhance our vision, or we need to enhance our audition, or we need to enhance the way that we interact with the system. Then when we talk about cognitive ergonomics, then this is basically how we focus on aiding individuals in complete tasks. It could be by themselves or in a collaborative way, because we can have peer support. But it's really important that when we are referring to consumer health informatics, they may have some diminished cognitive functions because they can have diminished perception, if they have some problems with the senses, but they also can have problems with attention, with memory, or even some learning disabilities. And then we need to understand that consumer health informatics interventions could be actual cognitive support for individuals, like the medication reminders for Alzheimer's patients, or enhancing visibility for low vision individuals, or enhancing communication, translating visual cues into audio, or even visual cues into tactile, like in Braille, that we can do that in different tools. And the macro ergonomics refers to data analysis in design or evaluation of the work and task itself. And the work includes any form of human effort or activity, and you can think about recreation, leisure, anything that we do. Work is not just formal work, it's just that activity that we are going to be doing to accomplish a goal. And they address what type of work for lay people, that they could be their workflow or the workflow of the system. And the workflow are the different steps to complete the task, or the system are the different elements that need to be coordinated to work. Then the scenario that they are bringing is how we can have a diabetic patient that uses high blood pressure and a glucose monitor, collect the data and be able to transfer that data to a health worker, and facilitate the self-management of the diabetes and their health outcomes when they are sharing that data with a nurse. And the nurse is using the same tool that is called Microsoft Health Vault to monitor the patient's symptoms and adjust the medications according with standard protocols. You may wonder, what is Microsoft Health Vault? Then that was a really interesting story or history of informatics, and it was in the early 2000s when Microsoft was trying to create this personal health record where individuals can have their health data and be able to connect different sources like pharmacy, the employees, the services, the hospital, the laboratory, physicians, the health plan, and collect every single thing in a single place that they call the health vault, and then the user was in charge of giving access to the others. This was a really interesting idea, but the adoption was really low, especially because people was not trusting Microsoft, a health tech organization, with their data. They were not feeling comfortable, and that's basically what didn't allow the thing to really pick up. And people, the different organizations, they were thinking, no, the data is mine, and if I share the data with Microsoft, they're going to be taking advantage of that. Then it was an environment that was not favorable to develop a really interesting technology. We are not going to be talking really in this paper what didn't work there, but just to mention, but just as a context of what Health Vault is. Then what is the study approach? Then they wanted to enable users to know their goals and tasks, but also they wanted to allow users to have some flexibility when they were interacting with the system and completing different tasks in the process. For that, they rely on 3 students. And why 3? Because hey, this is a really preliminary study of usability. And actually, nowadays, we still have the discount usability testing. Discount usability testing, it's about 5 individuals that we use to test tools. And what literature has demonstrated is the gain of knowledge about 5 individuals testing a system is not really that cost benefit, because those 5 are going to be really finding the problematic elements quickly and it's going to converge, and we don't need to have a lot of more individuals, because the investment is going to be a lot on time, effort, and the gain in knowledge is not going to be that much. In this case, they were using 2 undergraduate industrial engineering students that they were conducting the patient task, and the other student was a registered nurse that was conducting the nurse task. And what were those tasks? Then the student was given the patient was given an electronic blood pressure monitor that connected to a computer via an USB cord. And look at this, as computer, we are not talking about mobile devices, we are talking about 2009, the smartphones were just coming into the market. But the idea was just to connect with the computer, download the blood pressure monitoring, and they will have a list of glucose that they need to transcribe into the tool. The task of nurse was to change the patient medications according with the different measurements that they were being receiving through the platform with no physician intervention. Okay. The users then recorded in addition different things like the time spent in completing each task, different challenges that they encounter while they're completing the task. The patient users tested the systems where they were using limiting physical activity devices like gardening gloves to simulate the patient has arthritis, or they were interacting with screenshots with a limited visibility to simulate cataracts. And two external evaluators analyze and categorize the different things that the users reported, the different challenges in those domains that we already explained, in the physical, cognitive, and macro ergonomics. And these evaluators were they calculate the integrator agreement between the two evaluators and then provided a reliability on that agreement. Also, every single challenge was scored in the severity of that rating, and they provided a mediation strategy or a solution to the problem. And we are going to see that in the user-centered design, uh, the third framework, the function user representation task, is something that when we do heuristic analysis, for example, we focus on the negative aspects of the tool, but the most important is, hey, what is going to be a possible solution for that problem, and not just say, hey, this is not working, but we want to solve the problem in some way. Then all severity ratings were assigned by 3 evaluators for every single challenge, even if it was not a challenge that they identified. That's why the scale went from 0 to 3. Because if you don't agree there is a challenge, then you just give 0. But if it's low, medium, or high, then that's 1, 2, and 3. Now, the mediation strategies were developed for every single challenge, and they were using Cleck's socio-technical design principles to try to propose a solution. And basically, where they aim to improve the physical, cognitive, or macroergonomic fit between the consumer health informatics intervention and the lay people health work and the provider cares work. Results then present that those patient users, remember, there were only 2, they identified 49 unique challenges in 10 days. And the nurse was able to identify 8 unique challenges in that same period of time. Then it is clear that users face a variety of physical challenges, that they were even abroad of the design of the system. And one user noted difficult keeping the cuff properly aligned when securing the Velcro strap. The cuff basically was spinning because maybe it was not the right size, no? And look, that these are elements that were not really directly considered part of the system, but if they don't work, the task is going to be really more difficult. They also identify difficulties securing the USB plug to the computer, and that's something that if you have tried to attach a USB, most of the time it doesn't work, it doesn't fit, and can you imagine in an accessible location, it's going to be even more challenging. And the other thing is that the login to the health ball was extremely small, and it was exacerbated when they were using that cataract simulator. And let's look into those were the physical challenges. Let's look into the cognitive challenges. Then all of them encountered some kind of cognitive challenge for the use of the system. Then the monitoring instructions were confusing. They did not provide the trade-off of available monitor system, did not explain the error message when the cuff was not secured properly, and they did not explain that the device needed to be off when they were setting the time. Also, there was a confusion in the way that the health ball labeled different tabs in records, and sharing did not correspond to the functionality that they wanted to see there. And the sharing tab described types of data that you can share, but not was the place where you assign the permissions to share or actually send the data. is just to establish what is the type of data that you can share, and help also request potential confusing information from users like operating system and other stuff that were out of scope. And when they were looking into the macroeconomics challenges, then they found challenges related with the use of live ID login. That's basically the Microsoft Live was introduced at that time, that you have to have a Microsoft account to be able to log in there. And it didn't take into account the user's email preferences. Maybe they wanted to use Gmail, they wanted to use something else. And uploading was directly from the device, and much less cumbersome than manually enter information. And those are one of those studies that has confirmed that, hey, we don't want anybody to be transcribing things, because that's overloads the users, and that induces errors. And the other thing that they found is that HealthVault automatically uploads the readings, and that automation without login or password was completely invisible for the user at that moment. It was kind of lost control, and there was no feedback. That was what was happening there. Also, nurses' challenges center in how the information the health vault system interface with their current workflow, because they needed to go into a different system that the existing one that they were working on. And when you need to log in into different systems, that's also problematic. Then let's see several mediation strategies examples that they provide. For example, in the HealthVault link is extremely small. Then there was a physical challenge, severity of tool. And the mediation strategy is to include a screenshot on the HealthVault main page in an instruction manual with the sign-in link circle, increasing information visibility. This was kind of a initial mediation strategy, but we have learned with usability studies that maybe you need to make things silent, really highlight the principal task in the screen, and you want to reduce manuals. Actually, we have seen through usability, when you improve the interface, when you improve the screens, the less complex the manual are. And you can see nowadays in some electronics, they have the quick start, and maybe they have the manual, and every single time the manuals are smaller and smaller and smaller. And there are a lot of use cases in how just improving the interface you can get rid of the manual. Another one was about data automation, and HealthVault was not alerting users when somebody else has added or made changes in the information. Remember that the nurse was changing the medication, and then this is a problem of cognitive, not knowing, and severity is 3, because if you don't know, you are not going to have any action. Then they were proposing having at that time nurses calling the users and tell, hey, you have new information. But nowadays we have instant messaging, we have SMS, we have other type of alerts that can be automatized and direct the user to identify that change on state in the record. The other one is that USB cord connecting to the monitor needed to disconnect and reconnect to the device to be recognized. Then this was a macro ergonomic example, severity 1, and basically they say, hey, when you are training the user and you are using a scenario to train this, just tell them, hey, if it's not working, just unplug it and plug again, and maybe it's going to improve. Then this paper allows to see how we can systematically assess physical, cognitive, and macroeconomics fit, in particular consumer health informatics, and how lay people health work and provide care work can be integrated, and also allow to identify challenges that will be difficult, if not possible, when you have a laboratory-based usability study. Then this is one of those case studies that create a foundation for a scenario-based studying. You don't need to have real patients, you don't need to have necessarily real data. You can have simulated data, you can have people acting for the patients, or even you can recruit the patients, it will be much better. But once you define the process, and you can do this in small scale, because this is to identify those main problems that you can have in in an interface, and then this allow to introduce those concepts of this count usability testing, where I was telling you that maybe 5 is like the sweet spot to have when you are doing this. And anticipated to the homework that we're going to be doing, this is a key element. You don't need to have 20 observations, you don't need to have 30 patients, you don't need to do a clinical trial to identify problems in the interface or in a solution, because if you are focused on identifying those things to be improved and doing usability testing in that regards, then a scenario based to identify problems with a small sample size is a good approach. Then let's switch now gears and go into real patients. And this is another study that was by Ashish Joshi, when Lynch, Aurora, and Sears. It was also in 2009 and was published in the Health Informatics Journal. This is a prospective use of an interactive patient education and motivation tool that they call PEMT, placed with a pediatric emergency department, and this is another case study. Then, what is PEMT? PEMT is an interactive computer-based education and behavioral modification program, and it has 3 sets of learning theories. It grasps from the behavior, from the cognitive, and from the humanistic theories. And it has 3 components. It has a screening component, a learning component, and an evaluation component. The intervention basically was a touchscreen computer that delivered education about asthma. It was delivered to children and parents or guardians during their acute visit in the ER department, and it was designed to teach children about asthma and how they can manage it. Then each screen included text and audio. This is multimedia approach. It didn't have images, and information of each screen being segmented into 1 or more chunks. And this chunking is going to be really important when we review that concept of a 7 plus or minus 2. That's basically how our brain process information, that we can do operations in segments of 7 minus 2 or plus 2, and that's what makes us higher performance or low performance. But basically, you don't want to dump everything at the same time, because you are going to overload your brain. And they were able to track different aspects when they were navigating through the screens and the education program. Then the intervention has had 24 slides with information, and then 10 it was about basics of asthma, 8 about triggers, and 6 about management. And they established that the standard time for navigating this element was established to 398 seconds, roughly 400 seconds, like 6.5 minutes. And they were expecting that the basics can be consuming 120 seconds, that's 2 minutes. The triggers in 110 seconds, that's under the 2 minutes, and for asthma management is 160, almost 3 minutes. And they measure the data of the system was used, different user characteristics, the previous knowledge about asthma, the amount of time that they spend on each screen, and the different navigation patterns that they use when they were that they follow when they were using the program. At the end, they were able to collect 99 participants, and this was a prospective randomized pre-post study. Why pre-post? Because they have a questionnaire, that's the asthma knowledge questionnaire, that they apply before the intervention. They collected some socio-demographical data, they did intervention, and they ask again about asthma knowledge. And that's why it's a pre-post study. And it's not randomized because everybody received the same treatment, or everybody receives basically the tool. They were just evaluating the delta or the change and the different factors that could modify that learning in the process. Then they track the use of the tool through a series of interactions, and they have session IDs, the screen ID, time stamping, and the amount of time that they spend in every single screen. And remember that they already have the standard time to reference to. The findings that they report is that individuals spend less than the standard time when they were viewing screens, and therefore did not hear the complete audio for each screen. And also, individuals spend more than the standard time and allow the complete audio for each screen to be played. This is really important because and you may be watching this video at 2x, no, or even faster, because the audio communication is slow communication. Visual communication is a faster communication. Then it depends on the learning styles and our brain configuration. There are people that are going to be more visual, the others are going to be more auditory, but the combination of those and providing them to the users are going to be reinforcing the learning. But then you can identify who prefers what and how you are going to achieve the information, just analyzing the behavior. Then they concluded that optimization of form, duration, and context of the education module maybe impact the information gain using this interactive kiosks. Basically, yes, how you are going to present the data. And they wouldn't analyze the pure image, they just have the text and the audio. But what happens if we enhance this with images or videos, no? And also the order in which the different models are present can be tailored based on prior knowledge, because you don't want to repeat something that somebody already know. That's going to make them annoyed, or they're just going to be skipping. And perhaps if you have some piece of chunk of information there that you wanted really to highlight, but they were focusing on the first element that they saw, they may have a chance of missing that information. Also, to consider that this approach should enhance individuals' engagement with the system and lead to more effective delivery of the right information at the right time. Just when you want to reemphasize something in auditory, in visual, or how you want to interact that. Then, as you see, we have presented two case studies that they were foundationals using the scenario-based evaluation one that had non-real patients, but we have defined tasks and defined scenarios where the users were in real life and the users were having simulated conditions. And the other one was an real-time evaluation in the real setting that were evaluating a little bit more of performance. As I mentioned, the first one exemplified that discount approach and is more oriented to identify problematic elements, while this scenario-based evaluation that we were doing is to understand more the dynamics, and that's why the sample size is increased. Then again, here we have the two references, and thank you very much for your attention. Hope to see you soon.